Good morning, everyone, and welcome to this special IC member webinar event on Australian vaccine manufacturing. If I could have the next slide. So today we have Jonathan Anderson from Seqirus. Jonathan will be speaking to us today about Australian vaccine manufacturing. He's a Senior Medical Director for Seqirus Asia Pacific and was the medical lead on the UQ-CSL COVID vaccine. And before industry, he was a GP working in HIV and infectious diseases with interests in pandemic preparedness, clinical research and health economics. And prior to that, he's been the Regional Head of Medical Affairs in the Asia Pacific region for Seqirus, and he joined industry in 2010 after an extensive clinical career and academic work. His PhD was on the role of economics and the prioritization of treatment and prevention, and he also has a master's in public health economics. And the next slide, thanks. Just a little bit of housekeeping before we begin. There is a Q&A box you'll see at the bottom of your screen on the right, and this will enable you to ask questions. If you do that, which would be good, then I will be able to group those questions and then ask them at the end of the seminar. All questions will be asked at the end of the seminar. You'll also see a raised hand next to it on the left, and you can also press that and we will feed you in to ask a question verbally if you wish. But just to point out that it's possible that not all questions can be answered today, either because of time and number, or perhaps because answers have to be sought from elsewhere. And if that's the case, we'll put out a Q&A document through the Immunisation Coalition, which you'll be able to get online. So a pleasure to introduce you, Jonathan, and I'll hand over to you.
Thank you very much, Gary, and I'll just move to my next slide. So what I'm going to talk to you about today, first of all, is around Flucelvax, which is our cell-based influenza vaccine, which has been introduced this year, which will be manufactured in Australia from 2026. And I'll give you an update on our manufacturing project around Flucelvax, which will be both for seasonal influenza vaccines as well as pandemic vaccines. I'll also give you an update from the University of Queensland CSL vaccine project, which of course has come to a halt in December, but give you some ideas around some of the challenges that we faced in vaccine development and some of the challenges we face as a country in vaccine rollout. And I'm sure all of you are very well informed on this topic. So I thought it was a good opportunity to have a discussion around how we might solve some of the challenges. The purpose of today really is to present some data for discussion and conversation. And so first of all, I just want to give you a summary on what Flucelvax is. Flucelvax, as I mentioned, is the cell-based vaccine. Its indication is for adults and children of 9 years and older. And today, at times, I will be showing you data below 9 years, and I'll point that out along the way. This is a IM injection, and this contains obviously is a quadrivalent vaccine, and it's propagated in the maiden Derby canine kidney cells, which according to the source of all truth, which is Wikipedia, I think came from a dog's kidney in 1957 and has been a cell line that's been going strong ever since. It's a vaccine that contains both the hemagglutinin and neuraminidase, and the main contraindications around severe allergic reactions, either to components of the vaccines or previous doses. Now, this vaccine is new in Australia, but has been licensed in the US since 2016 with greater than 100 million doses distributed worldwide. So why have cell-based vaccines? Well, there are two main reasons, and I'll talk about both of them. One of them is to assist with the challenges of antigenic match, because egg-adapted viruses can be different to the circulating viruses. As egg adaptation can contribute to the vaccine effectiveness as well. And so the idea of growing them in cells is to try and keep them more similar to the flu viruses in circulation. There's also a manufacturing benefit for us. It improves our ability to control the processes. We don't need to use the egg supply, and there's opportunities for reducing the amount of antibiotics and preservatives that are needed. So all of you would know again that there are really three key areas that affect vaccine effectiveness. There's things like immunosenescence in the elderly. There's viral factors, drift and shift in the actual virus. But in terms of vaccine factors, there are a number of hemagglutinin mutations which are driven by egg adaptations. And these can cause, in some seasons, antigenic mismatch. And so really what we're trying to address with the cell-based vaccine are these vaccine factors. So a reminder of how the vaccines are made currently is the top row. And we basically create candidate vaccine strains in eggs, which are then propagated in eggs and then harvested, inactivated, purified, and mixed up and packaged. So what the cell-based vaccination manufacture process does is used candidate vaccine viruses are manufactured within the cell-based culture, and then they're propagated again in the cell-based culture. So there's no opportunity for egg adaptation. So this simplified schematic describes what happens. And essentially the reason for egg adaptation primarily is that these viruses, which obviously are infecting mammals, also infect birds, but the viruses grow best in eggs that are of avian origin. So the challenge really is to try and get the viruses to grow in eggs. So sometimes there's egg adaptation to allow them to grow in the eggs, to be able to get some yield in the eggs to create the vaccines. And sometimes this egg adaptation occurs during the process of either creating the cell seed or in the process of manufacture. So certainly cell culture is one approach to this. Another approach is to use recombinant hemagglutinin, and others are taking that approach. So what we're focused on is the cell-based culture approach. So this describes the match between cell-based or egg-based vaccine viruses in the Northern Hemisphere 2012-2013 season. And this graph plots how close the viruses are to each other. And what's important here is to look at the majority of the circulating viruses were closely related to the cell-derived counterparts in pink and red, whereas the ones that are egg-derived in that year had become different relative to the ones that were circulating. Now, the question really is whether this has an effect necessarily in every year. But this is certainly a feature that cell-based vaccines give the opportunity for closer antigenic similarity between the two. In summary, we can potentially have a problem associated with egg adaptation. And so we've worked to develop the flu cells vaccine. Just to help you understand the cell-based vaccines and cell seeds, the actual original licensure of the trivalent version of this vaccine was in 2012 by Novartis influenza, which was the part of the predecessor of Seqirus. And a quadrivalent version was licensed in 2015-16. But cell seeds were really only introduced in 2017-18 season. First of all, for the H3N2 strain, and then for the H3N2 and the B strains, followed by all strains in 2019-20. So what we have had prior to this year, prior to last year, was a vaccine that had cell seeds and egg seeds, but now they're all cell seeds, and then they're all grown in the cell culture. And as I mentioned, this was now licensed this year in Australia. So the clinical development program here is described according to the age groups. And a reminder again that in Australia, the indication is for 9 years and above. There was an efficacy and immunogenicity safety study of trivalent cell-based vaccine against placebo in adults, and then an immunogenicity and safety vaccine of the quadrivalent cell-based vaccine against the trivalent vaccine. And I'll show you the data from that in a moment. There's also been studies down to 4 years and 2 years in children, immunogenicity, safety, and efficacy. And we're still waiting for immunogenicity and safety down to 6 months, and efficacy also down to 6 months in the future. And there's a pregnancy register as well. So what you'll note here is there's not a comparison in our randomized controlled trials between the quadrivalent or trivalent cell-based vaccine with the egg-based vaccine. So what we're going to look at after I show you the randomized controlled trials is some of the real-world evidence as well of what's happened in use. So this is the headline for the trivalent cell-based vaccine in adults. And the primary endpoint here was efficacy, absolute vaccine efficacy against vaccine-like strains. And one of the secondary endpoints was the all-strain efficacy. And you can see the definitions there, which was lab confirmed. And really this confirmed that this was immunogenic and had effectiveness against the vaccine strains and was well tolerated. If we look at the immunogenicity in children and adults, what we see here in terms of the comparison between the quadrivalent and the trivalent vaccines is similar immunogenicity in children and adults for both the A strains and B strains, with immunological non-inferiority being met. In terms of adverse events for adults in these studies, we really saw similar kinds of adverse events that you might see for an egg-based vaccine, with most adverse events being of mild to moderate intensity, both in terms of local and systemic symptoms. And there was no vaccine-related serious adverse events. In terms of children, and of course this is very interesting for all of us, the adverse events in terms of solicited local symptoms and solicited systemic symptoms were very similar between where the control here was a meningococcal vaccine. And the rates of fever, particularly mild to moderate fever, were similar to what's seen with the majority of egg-based vaccines in children down to this age. So just to remind everyone, the technology that's used here for the creation of this vaccine is different to what the egg-based vaccines that are out there. So in terms of the summary, before I move into the real world evidence, we have good immune responses and the safety of tolerability is reasonable. So let's talk about real world evidence. And I know this prompts lots of discussions about the validity of real world evidence. So we've looked at a number of studies looking at the relative vaccine effectiveness of the quadrivalent vaccine, the cell-based one, versus the egg-based ones. And there are two kinds of studies. And here the color coding will apply through the next set of slides. There's the lab confirmed influenza, test negative retrospective cohort type studies. And then there's the non-lab confirmed influenza, which are generally from electronic medical records. And these give you the volume, they give you the large study populations compared with the lab confirmed influenza ones that give you the smaller numbers, but it gives you a specific influenza case definition. Like all observational studies, they're adjusted for major covariates, but do have unresolved confounders, which is obviously the limit of these kinds of studies. So here's the analysis of the relative vaccine effectiveness in populations aged 4 to 64, noting again that our indication at the moment only goes down to 9 years. And in the 2017 to 2018 US seasons, which is the top set of data, you can see a number of different studies there listed by from the Department of Defense, the Haven study, the Allscripts, and Archivia. And what you can see here is that in terms of the lab confirmed influenza, the point estimate favors the Flucelvax quad over the egg-based vaccine. In the influenza-related medical encounters and hospitalizations, it also favors Flucelvax quad. In the lab-confirmed influenza, the confidence intervals cross 0, but in the ones based on large databases, it becomes more precise, and therefore the confidence intervals don't cross 0. In 2018-19, similarly, we see point estimates which vary depending on the study. But what's interesting here is to see that the point estimates for the two influenza-related hospitalization studies are slightly lower than what you see in the 2017-18. And the key point here is that what we may see in 1 year may be different in another year in terms of egg adaptation. And this may relate to which strains were particularly dominant in that year, and therefore whether egg adaptation was a particular challenge in the production of the vaccine or in its subsequent deployment. If we look at the over 65 population, you don't need me to tell you that it doesn't look, except for one study, that there's any huge advantage in the Flucelvax quad compared with the egg-based vaccine. And I think here what we see is those other two factors applying. Potentially immunosenescence might be playing a role, or there may be other factors involved that aren't captured, that egg adaptation was not so important relative to those factors. So it's an interesting finding over 65. And while technically it would be licensed for that population, we know that there are enhanced vaccines, either high doses or adjuvanted vaccines for the over 65s that may more meet the needs around immunosenescence. Let's check my time. The summary here is to note that there's no randomized controlled trials directly comparing the cell seed viruses to those made using eggs. And part of that is this historical development of the vaccines over time, which started with the egg-based seeds and then moved into the cell-based seeds only more recently. The body of evidence is emerging over the last 2 seasons. And certainly, while there's in the laboratory confirmed influenza, the point estimates certainly on the right-hand side of the graph, these aren't significant. But in the non-laboratory confirmed influenza-related healthcare visits, the cell-based vaccines do appear to be more effective than the egg-based vaccines. And as I said, and I want to sort of reinforce, the difference may vary due to the seasonal variations, and certainly, as you can see, with age groups. And of course, there are limitations to all observational data, and we've tried very hard, and those doing the work in this area have tried very hard to think about managing bias, managing confounding factors. But there'll always be limitations in observational data. Of course, the challenge with RCTs can be that it tells you about a particular vaccine in a particular year in a particular setting. So the real world evidence gives you perhaps a different view on how these vaccines perform in the real world in the clinic. So I'll just move on to talk about the new Australian facility to make these vaccines. And this is called the Banksia project by us. And this is a biotech facility that will be in Melbourne, up near the airport, near Melbourne Airport. And this has a large investment, both from the Australian government in terms of biosecurity, as well as from CSL, which we're part of. And we're aiming to have this operational in mid-2026. So all our production will move over to cell-based production in the Southern Hemisphere but on that date or by that date. So we will be supporting a large supply chain with this, but we obviously will no longer need the eggs to make the vaccine. This gives us the opportunity for high-speed filling and packaging, as well as potential benefits for pandemic influenza strains, because one is always challenged with a pandemic to produce and to have enough eggs on hand already to produce the pandemic strain. As you can imagine, the chickens that produce these eggs are particularly looked after. And so to try and turn up the number of eggs produced in a pandemic is quite challenging. It will also continue to produce the antivenoms that Australia needs and the vaccine for Q fever, which is used extensively in rural and remote Australia. And here's a pretty picture of the factory. It looks very nice. The facility really will mirror what we have in our Holly Springs facility in North Carolina, which produces the Flucelvax at the moment. And in the future, all the production for the Southern Hemisphere will move over to this facility, as well as much of the production for around the world as well. So I'm just going to speak briefly about our experience of COVID vaccines. CSL has had a role in the vaccines as well as other initiatives for COVID, as I think you all know extremely well. We've been involved in a partnership with the University of Queensland, which I'll talk about briefly, and happy to answer any questions on that, as well as been doing some preclinical work on a self-amplifying messenger RNA that we have in our lab in Cambridge in Massachusetts, which provides some interesting future opportunities. We've also been lending our adjuvant MF59 to third-party R&D groups because of its role in the over 65s age group, particularly good for immunosenescence and antigen sparing. As a company, we've been involved in a global alliance around hyperimmune immunoglobulin. And we've also been looking at an immunoglobulin for the Australian market for the treatment of people with the disease. We've got a nice tie-up with a company that's producing immunotherapies using cows to produce the antibodies, which is a very interesting program. And we at the start took the approach that many other companies did of thinking about all the monoclonal antibodies that we had for other disease areas. Could they help for respiratory distress? And we've been manufacturing and have manufactured a number of batches of the Oxford AstraZeneca vaccine for Australia. I believe we're going to manufacture 50 million doses or 51 million doses of the vaccine as a contract manufacturer, but making it clear that we're the manufacturing on behalf of AstraZeneca. So I can't necessarily answer all your questions on their vaccine. So what are the challenges in vaccine development? Well, this was a new antigen. We hadn't had a vaccine against coronavirus, as we all know, and the platforms that we're using are all pretty much new in some shape or form. While people have tried to use things like adenoviruses before for HIV vaccines, for instance, they hadn't been deployed more widely. Some of the platforms, of course, have been developed for Zika and Ebola, but not really put into major action. From our perspective, we used the University of Queensland molecular clamp platform, and that was a platform which was aiming to hold the spike protein together in its native form. But of course, there's a potential for new adverse reactions, which I think the world is watching at the moment. this happened so fast. It's only just over 12 months ago that we had the first cases and first reactions around the world. And so things really move fast. We moved through phase 1 at the same time as getting phases 2 and 3 mashed together before we even finished doing all the preclinical work. There's a lot of discussion about worthwhile efficacy. Is a vaccine that's 50% efficacious, 90% efficacious? What do we need? Do we need herd immunity? Do we need individuals prevented from severe disease? When we were thinking about the design of our own studies, we were thinking about, do we try and hit the US FDA 50 or 60% efficacy? Or do we go for the Europeans who had a lower bound of the confidence intervals? So there's a lot of, it was a very interesting time to talk about efficacy. And then there's a balance of risk and benefit, which may not just be at an individual basis, it may be at a population level or even a healthcare system wide level. And in some ways you could say that was one of the challenges that we faced when we had not a safety signal, but really a communications and public health management problem. So the correlates of protection, it wasn't clear really whether this was a T cell or antibody driven protection that was required even from the natural infection. And would we get immune responses in the elderly? Would we get immune responses in people who are immunocompromised? Will we get immune responses at the levels we need? And certainly some of the vaccine candidates have gone back to the drawing board because they haven't quite achieved what they wanted to do in the over 65s. Interestingly, when we look at the data from the University of Queensland vaccine, the data in the elderly was probably about 60% lower immunogenicity in the phase 1, but based on the dose we were using, we were actually very comfortable that we would be able to achieve the normal dose by immune response by using the middle dose of the ones we were testing. How long would the protection last? Is this a year? Are those great results that we've seen from various people because that's the sort of early phase benefit of the vaccine? How will the vaccines be in a year? Will we need boosters? How does that work if you've had an agent like an adenovirus? Will you have antibodies to it? In our case, would you have antibodies to the University of Queensland molecular clamp, to the clamp? Would they have an impact on durability as well? Safety, obviously critical, 100% the most important thing in terms of vaccine development. And then how will we store these vaccines? That's well rehearsed. I think everyone knows that. But distributing multi-dose vials around the world to a population of HCPs, perhaps who haven't used multi-dose vials since 2009 pandemic. In fact, that was the last time I used a multi-dose vial. And the concerns that we've all had in the past about multi-dose vials, including contamination. So what kind of spike antibody responses did we get in phase 1 from the University of Queensland? And this is unpublished data, but I'm happy to share it. On the right-hand side, you can see here the geometric mean titers for the vaccine, which was called V451 in our coding with the University of Queensland. And at the 3 doses, we got nice geometric mean titers. If you compare those with the human convalescent serum, quite interestingly, at day 57, the actual 15 micrograms had the best GMT. We think that was a bit of an aberration, but we would have gone with the 15 micrograms, I think, anyway. But compared with the human convalescent serum in this, we were overcoming the levels that were found in human convalescent serum. If you compare these against the phase 1 data that was available for the other vaccines, and you can note there that different assays were used. So you should really compare the light blue bar with the yellow bars for each study, because they all use slightly different assays. But you can see that the University of Queensland vaccine was there or thereabouts with most of them. And quite interestingly, similar to the Pfizer BioNTech, Novavax looked like the the one that's got the highest GMTs, but of course in their assay they also got the highest human convalescent serum. So in terms of the race, the hurdles that we were trying to leap, this was looking really very good, very nice. And then we hit a hurdle, and the hurdle was the clamp, which was derived from GP41, glycoprotein 41 from HIV, which is a particularly good glycoprotein to hold something together. But unfortunately, in the test that we did to look and see what impact it would have on HIV assays, you can see here some antigen results, antibody and antigen results for the HIV assay. And what you can see is that we were getting essentially signal on the architect assay, which is the Abbott architect is widely used. About 60 to 85% of testing for HIV around the world goes through this test. And we saw this signal at day 57, which diminished over time, but not really fast enough. Over 2 months, it went down somewhere between 4% and 50%, but the average was about 30%. So leaving a signal where people would get a false positive on certain HIV tests, not on others, but on the ones that go through these high throughput labs, it was really quite a challenge. So we spent a lot of time thinking about this, and the University of Queensland worked hard to think about whether there's any modifications for the clamp. You can see here in this diagram that they used 2 fragments of the clamp GP41, not the whole of GP41. And the idea really of those 2 fragments were they weren't supposed to be the immunodominant parts of GP41. But unfortunately, they are quite immunostimulatory for creating antibodies. And those antibodies actually, when we looked at Western blots, were against GP160, which is GP41 is one component of, rather than GP41. So we talked for a long time with a whole bunch of different experts from places like the Doherty and the Kirby, as well as talked with our advisors. And in due course, after much discussion, decided that this would be really a very difficult challenge in terms of public communication and might affect confidence in vaccination programs. And also, it could have a potential impact on public health programs for HIV, affecting testing and self-testing and rapid testing in a way that was greater than we could sustain in terms of continuing the development. So this was an interesting example of some of the challenges that come up in vaccine development, where you get unexpected hurdles. Obviously, we knew that this was within the molecular clamp, but we were understanding that this wasn't going to trigger HIV tests. So what other challenges are there in vaccine development? Well, making these things in huge vats is quite a business, and certainly as a doctor, I've learned a great deal about manufacturing over the last year while I've been working on this program. We managed at CSL and Seqirus to make large amounts of the vaccine candidate, and we're happy to make the vaccine for the Oxford AstraZeneca vaccine now. And from our perspective, we've been very pleased that our network could deliver that. There's also a lot around the implementation programs, and I'll just talk about populations in a second, so we all can remind ourselves of the numbers that will occur at the time. I mentioned multi-dose vials and the concerns about contamination, which I, as a doctor who had an interest both in HIV and pandemic flu, was very conscious of in 2009, because we had talked a lot about contamination by people going back into the vaccine vial by accident. Storage, we all know those discussions around how we're going to store them and logistics. Luckily, the multi-dose vials reduces the volume a bit, but certainly they're significant issues. Competing vaccine programs, we're in the flu business, and I'll talk about that in a second. So that's really important to us, but we also have vaccines in other areas. And how will the vaccination programs for those be affected? Coverage, herd immunity, we can have a conversation around that. And the impact potentially on vaccine hesitancy if we have adverse events or poor communications. So in terms of the strategy, I think you'll all have seen this slide that the government's been using, but there's a lot of doses that need to go out all at once. If you look at phase 1B, up to 14.8 million doses. Now, the doses, as the government talks about, will not necessarily all be available all at once. And so managing who gets it when and how and their follow-up, I think is one of the greatest challenges the health system has faced. I think it's up to it, but we're obviously working now as a manufacturer to assist in this process. But we're particularly interested as a flu company in what will happen in terms of co-administration and the challenges of how we manage parallel co-implementation, not co-administration necessarily, of flu and COVID. There's no data on co-administration. Is the recommended interval 14 days? Is it 7 days? Various authorities are making opinion on this because there is no data yet. There is one study with one of the Novavax vaccines with our vaccine with Flucelvax and with the adjuvanted flu vaccine in the UK, and so there should be some data around that in the future. Should we delay or should we accelerate the influenza vaccine campaign? And how do we make sure that people don't get confused if they do need to have 3 shots? Their flu shot plus the 2-dose COVID vaccine. How do we make sure people get that really clearly communicated to them where they need to come back and when? We know that this could affect the uptake of COVID, can make people say, well, I've had my vaccines for the year, I don't need to have any. And of course, people look at last year's flu numbers and say, wow, are we going to get flu? And again, we can have a conversation about that. And then there's public health campaigns between the COVID vaccine campaign and flu. But clear messaging will be essential. We had great messaging and great collaboration between the different parts of the healthcare practitioners as well as the government and other stakeholders this last year. And let's hope that we can have real clarity. And we certainly that's an important discussion to have. So I'll just finish with the minimum product information for Flucelvax, but go back perhaps to Gary for some conversations, and I'll just see if I can stop sharing. Pause share. I can always share again.
Yes, you can, and we'll need you to share slide 22. There's a question about that, so we'll take that.
Okay, I'll get that up again, Gary, while you're talking, if I can.
Yeah, but don't share it yet because there's some other questions ahead of that. Thank you so much, Jonathan, for that excellent presentation and overview, and so many questions there, particularly towards the end, that I'm sure have got everybody's mind racing away and thinking about things. I might just ask a very simple question first myself, and just about the cost of the cell culture vaccine compared to egg-based. Will that be more expensive in Australia or elsewhere? And I suppose going with that, do you think developing countries might be able to take up this kind of technology and also provide vaccine in the various regions that they are? Or do you think egg-based might be here for a while?
So I think that the cost for the coming season will be private. So we're launching it really just into the private market. And I understand from my commercial colleagues that the cost will be just under $40 for dispensed at a pharmacy. And that compares with about $20 through, depending on where you go as a kind of recommended retail price. Obviously, as we know, it's a highly competitive market in terms of price, but the value of a vaccine or a medicine isn't just about the components of it. It's around the research and development that goes into it and the potential value for patients. So to answer your second question about will we see a transfer of this technology to being used more widely in low to middle income countries in the future, I think so. I think there's always time that takes for these things to generalize, and innovation tends to start at a certain price relative to the existing medicine or vaccine, and then kind of come back down over time relatively as competition occurs. It does provide an opportunity for making a lot of vaccine very fast. The rate limiting step can actually be the fill and finish. So that's one of the reasons why the fill and finish is more important.
No, sure. John Litt asks a good question. Will the enhanced timeline for cell culture vaccine mean that WHO recommendations for cell culture vaccines may be closer to the Southern Hemisphere flu season? In other words, a bit later. So would you expect it instead of being, it might be a month later or two? I'm not sure how that will work out. But do you have any thoughts on that?
Yeah, it's possible. We haven't got to that stage. We haven't got to that stage yet of changing what is a very well established protocol, and they usually they've all booked their flights for the next one, but this, they'll be doing them virtually for a while. I think that as we see the rapid adoption, not of cell-based or recombinant technologies, there are other technologies coming through. We may be able to get closer to the season with all of those, and of course, in the development of the coronavirus vaccines is the interesting prospect of messenger RNA vaccines and other things like that, virus-like particles for the future.
I'd hate to bring it up. There might be the spectre of having recommendations for egg vaccines and recommendations for cell culture that might actually be quite different.
Well, they do already have recommendations for certain strains as for cell-based vaccines and egg-based vaccines. And this is the thing that, when we talk about egg adaptation, this is egg adaptation in action, that really you need to make the virus be able to grow, the vaccine candidate viruses grow in eggs. They might be precisely the same as the potential circulating strain, but if they are just the same but they don't grow, then you'll not yield any to grow.
Yeah, John has a subsequent question as well. How many seasons in the last 20 years in Australia has egg adaptation been a significant issue?
That's a good question. I think I can answer. There's a graph which I didn't bring even in my backups. I would say it's about half. That's just but I'll get you a precise answer, John, and answer that through the IC.
Okay. From David Muscatello, in the studies comparing cell versus egg vaccine effectiveness, what were the actual effectiveness measures?
Okay, I'll bring up. I think that's the real world. Yeah. I'll bring up the real world evidence. Just bring that up. So what were the absolute vaccine effectiveness of each of those? Is that what you're asking? Sorry, I'm just...
Well, the question was in the studies comparing cell versus egg vaccine effectiveness, which I think you have up there.
Yeah, I don't have the numbers.
Effectiveness measures. I guess it's in the references, is it?
Yeah, I think it is. So yes, I think it is. It's in the references. Let me just have a think about that answer as we're talking.
And just a comment to David, if you want to use the raised hand thing, you can ask that question further if you wish. But in the meantime, I might go on to another question. So just talking about the AstraZeneca vaccine, will you manufacture a half dose? So there's a loaded question for you.
Yeah, we're making it according to what AstraZeneca has asked us to make, and I don't believe we're making a half dose.
Right. Okay. So I guess that will then set people's minds going about the efficacy of that vaccine being less, according to current data anyway. And there's another question from Anthony Hochberg on the AstraZeneca vaccination. Do you have any information on the timing in first trimester pregnancy?
The short answer is no. There's very limited data of any of these vaccines in pregnancy that I know of. I would assume that they would have had some people who would have found out they were pregnant having received the vaccine and may have some data in due course. But in general, the data is very sparse on pregnancy. I just probably would, and just Gary, going back to the question I think that David asked earlier. So the way these studies work, for instance, in terms of influenza-related medical encounters, is really looking at the databases that are available, and then looking at how many patients presented with certain codes in their electronic health records, and then trying to ascertain which vaccine they had and whether there's a difference in the rates of them based on that. So it's all about which of the outcomes you're looking at. I think that answers your question, but I'll ask one of my colleagues if they later on will come back to the IC with a proper answer on that.
Well, just on that AstraZeneca vaccine, if you're doing 51 million doses, I think you had a timeline for flu vaccines before, but I guess you've got a timeline for AstraZeneca.
Well, yeah, so the AstraZeneca vaccine, what the government said, and I can only really quote the government on this, is they're hoping to have these vaccines available, not just the more broadly. They haven't said which ones when, but they're hoping to have them by March. They talked, but I'm reading the newspapers on that. We're making them according to the schedule that AstraZeneca gave us. It won't necessarily produce all the vaccine all at once because there's a limited fill and finish.
Yeah, of course. And with regard to vaccines for Australia, we will have 3 or 4 in Australia. Let's say we'll have 4 by the end of the year, 4 different ones. Do you have any comment on the unfortunate, perhaps likelihood of mixing and matching? I mean,
I don't think I would mix and match.
No, I don't think I would either. But I just wondered.
But I don't think I think certain of the vaccines look like they're good for the pandemic phase, and some look like there could be more ones that you could have more as a seasonal vaccine eventually. I would probably comment it's like that. I think it's going to be one of the critical parts of communication between a vaccinator and a patient receiving the vaccine of which one they had, because I really wouldn't want to necessarily test out mix and match between an mRNA and an adenovirus.
No, sure. And I guess related to that is the thing of getting, is there any information on taking influenza vaccine, which is obviously a critical vaccine still to take, particularly for those at risk, and COVID at the same time? Can you take them concomitantly, or is there no information on that?
There's no information. We know that various authorities are now giving their opinion on it. Just recently, for instance, in the UK, the NHS have put out an standard operating procedure for their vaccine to say if you're faced with a patient that you think really you're stuck about trying to get them to come back to separate the vaccines out, then giving them together might be a reasonable thing to do. But it's really still opinion based.
Yeah. If you don't mind going to slide 22, Alan Hampson has a question.
Oh, that's a hard, that makes me...
Slide 22 he refers to, and he says, what's the comparison between standard dose cell-grown and standard dose egg-grown vaccine? Or could the lack of benefit in those over 65 recipients be due to high dose or adjuvanted egg-grown vaccine? So I think we'll have to study the question and the slide.
Yeah, I think my understanding of this is that these were people, despite the fact that we would all encourage people to have the the enhanced vaccines in this scenario. I think my understanding is these were people who may have been given the standard dose who were over 65. So the other factors that may apply here may be that the impact or the benefit in terms of the cell-based vaccine doesn't overcome those other factors related to immunosenescence.
Right. So there is some success with the adjuvant and high dose current vaccines, aren't there, in those over 65?
Yeah. So I haven't shown you the comparison of adjuvanted vaccines against standard vaccines, but there's across the body of evidence for real-world evidence for both high dose and adjuvanted vaccines. There appears to be a benefit in the population over 65 in terms of the relative vaccine effectiveness.
Right. Well, we still have a little time left, and we've got a hard stop at 1 p.m. Melbourne time. So there's still one question. I thought we answered this one. How many seasons in the last 20 years in Australia has
we have. That was from John Litt, I think, the second.
Okay. So I might ask one more question, if I may, and that is to do with the UQ project that you had and the clamp. So is there any value, I mean, given the vaccines seem to be so good, is there any value in trying to replace a GP41 with a different protein?
I think the University of Queensland are definitely looking at that. From our involvement in this current pandemic phase, we'll obviously watch to see what they do. But we do feel, and we've said this publicly as a company, we do feel we've probably missed the boat on that. So we're putting our energy as a company into the manufacturing of the AstraZeneca vaccine, as well as the future of things like self-amplifying messenger RNA and other technologies for both coronaviruses, but predominantly, of course, for influenza, which remains our core business.
Yeah, no, fair enough. Now, are there any other questions? I don't have any more on Q&A, but if anybody would like to ask any more questions, now is your final chance in the next few minutes. Meanwhile, I think the other issue is with egg versus cell. Is Seqirus thinking with the cell culture to give a higher dose, or are there more studies that need to be done for those over 65? Or have you already done those studies or added the adjuvant MF59?
So the cell-based vaccine that we've currently got indicated is the standard dose of antigen, similar dose to the other standard vaccines. And in the future, we obviously will look at different options in terms of the configuration of both antigens and adjuvants and other things in our vaccines.
Okay. Well, before we close, there's one last question that's come in from Peter Eisenberg. Any thoughts towards application for NIP?
Yes, thanks, Peter, and nice to hear a question from you. So we will be looking towards the National Immunisation Programme for future seasons. We're building up the body of evidence required to go through the ATAGI and PBAC processes, which takes a while, as we all know. And we're aiming for future seasons definitely to have this on the National Immunisation Programme.
Thank you so much, Jonathan, and thank you so much for excellent answers to all those questions and a really, really informative seminar. As I mentioned before, there might be a Q&A document online. Now, I believe there are some surveys at the end of this, and I just wanted to encourage all participants to fill out any surveys that might come your way, which is important for future suggestions for the IC. So thank you again, Jonathan. Thank you everyone for participating, and I think we'll have a close at this point. So thank you again.
Thank you for your time. Thank you.